starting recording now. Hi, Alison. Thanks for joining us today to talk about your service and your project that you worked on. First of all, just a brief introduction to the Level 1 students. If you could just say what your client group are and what your specialist area of physiotherapy is.
Sure. So my name's Alison Barclay. I'm currently an advanced practitioner physiotherapist, and I work in the physically disabled rehabilitation unit, which is about to be renamed as the neurological rehabilitation unit at the Queen Elizabeth. And the client group that I work in is with sort of physical disabilities or neurological rehab. My role is a split role. So at the time I worked as a highly specialist physiotherapist, and I worked split between outpatient clinics and in dealing with spasticity management, which is a particular issue for a lot of the patients I see. And I also worked part-time in our inpatient gym.
Great. We're obviously talking about service change and delivery and how leadership has had a role in that for you. What prompted you to consider the need to adapt the service that you had at the time?
So the project that I did was really around the outpatient services, but it is also applicable to our inpatient clients as well. We were looking at, we have a real lack of sort of clinician availability within the spasticity service and looking at advancing roles. So I had undertaken a module to allow me to prescribe, so the non-medical prescribing module at GCU. Because we were looking at my role being working towards an advanced practice role, which I'm now in. So I work now as an injector and a prescriber of medicines to treat patients with spasticity management. And at the time, after completing my module, I realised that we weren't really following hospital or governance really with the use of the medicine botulinum toxin, which we use to inject. So to allow me to follow legislation and follow policy, I realised we needed to develop a protocol or policy for use that really ensured safety for the clinicians that were using it and the patients as well. So yeah.
You've named a number of people there and influences on the project. Who would you say were the main stakeholders that were involved in your service design?
So it was myself, I suppose the consultants I was working alongside. We also involved highly specialist neuropharmacists within regional services, and I was also working alongside the clinical service manager. And then once we developed the protocol, it went to sort of senior management boards as well. But I suppose the main focus was around patients too. Because it was really around making sure we created something that gave the treatment to patients at the point they needed it, rather than them having to apply to use the medicine and for them to come back to another appointment maybe 2 or 3 months down the line when they need their treatment there and then they need to be able to access it. So it was around improving access to treatments, I suppose.
And what did you hope you would achieve through the actual service redesign?
So I suppose it was, as I've said, it was about improving access in a timely way to treatments for patients, because that's what a lot of our white papers recommend. Treatment should be at the point of need rather than on waiting times or clinician availability. The problem also was that we weren't maybe completing paperwork that we should have been doing and accessing the treatment anyway. I guess I realised from a self-governance and in terms of my sort of standards and legislation that we follow in relation to the CSP and HCPC, I needed to make sure I was doing everything in a safe and legal way. So really it was to facilitate me being an advanced practice clinician as much as improving the safety within the department, if that makes sense. So the treatments had already happened and had always happened. It's just we weren't maybe following the policy and procedures that we should have done.
No, that's good. I mean, there's obviously a couple of areas of measurableness there, if that's a word. What measures of outcome or impact did you actually use with either demonstrating these clinical benefits to the clients, or indeed demonstrating that the kind of safety elements were being met with respect to the service?
So we did some patient satisfaction because when I raised this as an issue with pharmacy, they wanted us to actually start filling in the necessary paperwork. So we had to apply for use of the medicine. It had to go to a special board meeting that happened once a month or every 2 months. That really slowed down the process. So we might identify from a patient that they need treatment. We'd have to apply for it for the use. It needed to be signed off. And then we needed another appointment to bring them back to access treatment. So some of it was around clinician and patient satisfaction at the start and then at the end. But it was also around showing the use of an advanced role within the service. And actually, if we got the necessary legalities signed off, I could then treat and provide patient care. And it was around cost effectiveness. So we looked at the cost of seeing me as a clinician versus a consultant or a registrar, and there was a huge cost saving. And it's not all about cost, it's also about seeing the right person at the right time. And I would argue within rehab services that therapy is key. The physical management plan and the treatment and exercise component is just as important. It goes alongside the medicine management. So actually patients seeing me probably more appropriate than seeing a consultant in lots of ways. So it's actually cost efficiencies for the service, and it frees up consultants' time to deal with maybe more complex care. So some of the patients that are coming in.
That kind of follows on to my next question. And my next question was going to be, what was the impact on other associated health and social care services as a result of your service design? So
again, freeing up clinician time, seeing the appropriate clinician at the right time, improving access to treatment, I would say. We created a more efficient, effective flow within our service, increasing our capacity. We get a lot of referrals in from, I suppose, GPs, from therapists, from other specialties, asking for input. So it allowed us to triage and be more effective and efficient with the service that we provide, I suppose, because there are limited clinicians in the service. So it's probably better to free up consultant time for what they're actually the best use of their time, I suppose. So it allowed us to look at all of these avenues as well.
That's great. So it appears to have been an effective service redesign. Do you plan to review the development cycle at any point?
I suppose we have already, because we did this several years ago. Actually, it was probably back in 2017, and we have looked at the model of the service that we provide, and it's been successful in terms of my role within the service and freeing up other clinician availability. So much so that we've actually applied for more funding to run a Band 6 injector clinic. And that's been just approved. So we're in the process of setting this up. So there'll be other therapists who are now injecting within our service.
So you see the development of that through the kind of ongoing evaluation, and it's obviously been a success, although we have added more funding to the existing service.
It's different. It's very difficult to actually measure it, other than because these patients would always have been seen. However, it has, with the change in services that we've got with the introduction of major trauma and complexity of patients, it's allowed the consultants to triage, and our waiting times haven't, our referrals have gone up, but our waiting times haven't, because of the introduction, I suppose, as me as a clinician, as an advanced practitioner. So we've been successful in implementing a therapist as an advanced practitioner, I suppose. So now they're looking to support it by other clinicians, which is great.
I suppose I've got one final question. I know I've brought this one in kind of fresh because I didn't tell you I was going to ask this one, but how has your service responded to the pandemic in the last 2 years? What kind of major challenges and have you had to cope with, and how do you feel things are settling, if at all, at this point?
So I suppose our service has always been, we were kind of prioritised as a key service. So we had disruption for 2 months within, 2 or 3 months within outpatient settings, and then we were allowed to see our patients again because it was deemed as essential. Our inpatient settings probably been more affected because we had a mixture of in and out patients that came in to access therapy. We used to provide a day case therapy programme, which ran sort of over 4 or 5, 6 weeks. And we had a mixture of in and out patients, so we haven't been able to do that. And we used that to do a lot of step down work with a lot of the patients who'd maybe come to us, had an extended period of rehab, and to bridge the gap between access and community services, which were decimated obviously with the pandemic. So what we did was we actually started using Giraffe to deliver sort of online therapy, and that's been developed and run by sort of Dr. Elaine Coulter and Professor Paul, who are based at GCU. And we implemented that as a sort of 6-week discharge service for a lot of our patients, where we set them up with an online exercise programme, and we reviewed that every couple of weeks and discussed and progressed it with the patient, again, just to try and give some sort of access to therapy. It was really good. The patients found it really good, and as I say, it allowed us to bridge a gap that was there. But we're still very much in the recovery process, because we still can't mix in and out patients as yet. So what we used to have as a day case therapy programme, I don't think will exist as it used to. It will certainly not in the short term anyway.
Right, well, thanks for that. It's been really interesting to hear not just your project, but how things have developed over the last few years with your service. I know that the students.
The other thing just to add, I suppose the other thing just to add is that you take for granted, it's the use of the online platforms like this, so like Teams and Attend Anywhere. So we were very much a face-to-face consultation. We're now much better at using remote consultations in this style with patients. So obviously when a patient needs an injection or an actual hands-on treatment, they have to come in. But for reviews, and we can do them online, and we've certainly moved to that model now as well. So, and we do that sort of for lots of our different clinics and inpatients as well. So it's certainly helped the NHS embrace technology, because we certainly weren't that great before. So it was just to add that as well.
Oh, thanks very much. In fact, it rolls on from last week's lecture with Leslie Holsworth, so that's fantastic. That just slots in lovely. So just to say thanks very much for your time today to tell us about your service redesign. I know the students will meet you next year, because you're also part of our team now.
They just don't realise that as yet. So yes, I teach in the neuro rehab module, so I will see you all next year. That's the best module that's taught at GCU, so that's why we leave it to level 2.
Well, thanks, Alison. I won't start and argue that at the moment. But listen, thanks very much for joining us. Thanks.
No problem.